Myopia is a big problem in Singapore. It's such a big problem that I think we can almost call it the home of myopia. And in fact, it's so common that in fact our research institute logo is a myopic eye. So that's how many patients we see with myopia. Because national service is still undertaken in Singapore, if you look at the constricts, people coming for national service in Singapore, normally around about the age of 18, almost 85% of them are myopic. The problem with myopia is that it's not the fact of low grades of myopia that we're worried about, but what we're worried about is pathological myopia. So what we want to prevent is people becoming -6, -7, -8, -9, -10, because that's where it's associated with serious complications. We all know you are higher risk of any retinal problems with being a high myope compared to being a low myopia itself. And that's really what we want to prevent from happening. If your child is becoming myopic at the age 2 or 3, you can guarantee when they hit early teenage years, they're going to become more myopic itself. There's several factors that basically, or why myopic progression has basically increased. If you look at the same children, say between Singapore and say Australia, Australian children generally at school do a lot more outdoor activities, generally more indoor activities as they do in Singapore, or more book working. That will increase your trigger for myopia because you're doing a lot more near focus accommodation, and that's been shown in several studies. If you look at the same sort of Chinese population in two different countries, generally in Australia versus Singapore, the Chinese kids in Australia have less degrees of myopia compared to the same children basically in Singapore itself. The treatment or stopping progression is really the goal itself, and there's several treatments that have been advocated. One of the popular treatments that's been used in Singapore has been orthokeratology. Now, orthokeratology involves wearing a contact lens at night time that will alter the shape of the myopia itself, and then during the daytime you normally take the contact lens out. The main worry, or the main things that I've also seen from some patients who've had orthokeratology done, is infection, because these are often born in young children. If you do get infectious keratitis, often the child will be left with some sort of visual deficit from the scar from the infectious keratitis itself. The ortho-K lenses, however, have got better, and there's several studies published in literature showing you that ortho-K does actually prevent the basically myopic progression itself. So it does work, I think, but it has to be balanced against the risk of myopia. Previously, studies about maybe even 10, 15 years ago showed that atropine works itself. So 1% atropine, there's no question it does slow down myopia. The problem with atropine at 1%, of course, is the side effects. Because you get dilated pupil, you're going to get blurred vision itself, and you're going to get photophobia for the children. So often the children are incapacitated with lots of problems. So work at SERI, Dr. Audrey Chia, who's one of the heads of the pediatric department at our center, has been doing this work. She's been looking at different doses of atropine itself. And what they've found, they recently published a paper in ophthalmology, probably end of last year. They showed that using low-dose atropine at 0.01%, they were able to slow the rates down of myopia down significantly compared to the higher doses. So it's not the fact that the higher doses do not work, it's just that the lower dose worked, and you did not have the side effects that you have with higher dose atropine. What they then went on to go and show, which is what in the most recent study, is that if you look at 3 years, if you stop the atropine medication and you look at what happens to the children who are myopic, the kids on the lower dose had less rebound than those kids that were on the higher dose of atropine. So it will rebound after you stop after 3 years, but there's less an effect with the lower dose compared to the higher dose atropine. Interestingly, what they basically also found was that the atropine did not seem to retard the axial length expansion, but it has some sort of effect on the accommodative amplitude to reduce the myopia. So what it means is that it's not the fact you will not be myopic, but it will prevent you from being these high extreme, or what we call pathological myopia, which we know is associated with a lot of complications.